Welcome to another podcast created and sponsored by III. It's a privilege to have among us today Dr. Ole De Backer from Denmark, and he has a huge experience in the treatment of structural heart disease with transcateter therapies. Also, the director of structural heart program here at InCor, Fábio Brito, will start with his first question.
So Ole, thanks a lot for being here. I would like first that if you can tell us a little bit about your practice, how you are dividing, you are doing coronaries, you're doing only structural, how is that in your place?
Yeah.
And also if you can tell us a little bit about the TAVR program in Copenhagen, about patient access, how you select patients for TAVR. Tell us a little bit about this, please.
Yeah, sure. No, thanks you for having me here, first of all. Well, the thing is, I'm a structural interventionist indeed. I became that. So I do now around 18 years of interventions. I started out with the coronary interventions, of course, but because the structural program has been growing that much over the last 10, 15 years, the volumes became that much that there was actually a demand from the hospital to specialize. Yes, specialize into a certain field. Like you have in PCI, people specializing in CTO, it was time to specialize into structural. I do the last 7 years only structural interventions. So it's my bread and butter, my biggest amount of procedures is still 2/3 or 60% is TAVR, so transcatheter aortic valve replacement. I have also a nice mitral and tricuspid program. And then beside that, so that's the 3 valve treatments. And then congenital I don't do. That's another colleague who does only congenital pediatric. But I also do left atrial appendage closure, PFO closure, ASD closure, and then some, together with my colleague, the TVARs, the thoracic endovascular aortic repair, the grafts. So that's what I do. So I'm day in, day out busy with the structural, and your question was specifically about aortic stenosis patients because that's the biggest volume. We do around 550 cases a year. So that's a high volume throughput of patients that has to pass through your hospital and successfully and easily get discharged again. So how do we do that? That's a bit your question.
Yeah.
Well, every patient has to pass the HARTI meeting. That's an obligation. That's mandatory for the Danish state even to get reimbursement. So we cannot just directly accept patients for TAVR, or the surgeon cannot directly accept for surgery. If we do that, we can do it, but we will not get our money, our reimbursement, so nobody does it. So we have to pass these patients through the HARTI meeting, which I think is a fair deal. And how does it go? Well, these patients, aortic stenosis patients I'm talking about, they all, since a couple of years, since 4 or 5 years, they all have to have a cardiac CT up front. Whether you're 85, you're almost for sure going to TAVI, or whether you're 50, you're almost for sure going to surgery. But we made it mandatory that every patient with an aortic stenosis needs a cardiac CT. And that's not only because that sometimes in the gray zone patients is important to get anatomical criteria that favors TAVI or surgery, but also even for me, if it goes to TAVI, you need your CT anyway, but even for the surgeons, it's very good to know, is there a porcelain aorta? Is there an extremely small annulus in these younger patients? This information he didn't have 10 years ago. And now he has, and he also looks at it. We report these reports. It's my fellows typically who do all the CT analysis before the HARTI meeting. So this is extremely valuable information. Then we discuss these patients at the HARTI meeting. I would say we follow kind of the European guidelines. If you're 75 years of age or older, and you're suitable technically for TAVI, he goes to TAVI. And this discussion doesn't take too long, to be honest. I mean, we discuss every day 8 patients on the HARTI meeting with valvular heart disease. And 10 patients with coronary. You cannot spend 20 minutes per patient. So these patients are sometimes in 2-3 minutes. Yeah, okay, TAVI, nobody objects. Okay, fine, next patient. If he's younger than 65 years of age, yes, and there is no contraindications for surgery, he goes automatically to surgery. I will not interfere in that too. But sometimes we have these patients, that's like a 58-year-old patient on dialysis or extremely overweighted or liver disease, or there's
Post-radiation.
Yeah, indeed. Every year we also have 2-3 years Hodgkin with radiation. Some patients they are very well informed. They go on the internet. We have these few patients also who they want TAVR. Yeah, okay, then you have to do it if they really refuse. So we have a couple of these patients too. And then of course you see the discussion where most of the time will be spent on is then these 65 to 75-year-old patients. And I do regularly in my practice now already 70, 71, 72, 69. We do these patients, yes. So of course there it's, I would say the CT is key. I mean, of course, some comorbidities of the patients, if that can tumble, if there's two or more comorbidities, it goes typically to TAVR. On the other hand, if there's on CT some challenges like bicuspid, excessively calcified bicuspid, really big anatomy, where we think, well, this is not a walk in the park TAVR, then this, and there's no other contraindications for surgery, we will maybe push them more to surgery. So that's what's been taken on the heart meeting. And then I think about the TAVI itself, we really evolved to a minimal approach. We don't have anesthesia in the room, so 96% of cases are transfemoral.
Echo?
No, echo in the room, no. They all get an echo the day after at discharge.
And you call the echo if needed?
Yeah, only if needed. We do, of course, I think there's three modalities for, if you talk then about PVL, if you want to screen for that, you have hemodynamic, you have your aortic root injection, the classical one. Then I look a lot to hemodynamics too. So I take my hemodynamics, ventricular aorta, and diastolic separation, etc. Before TAVI, after TAVI. If that looks good, my aortic root injection looks good, I'm good. And it's super rare that misleads me. Really, extremely rare. So I think we don't have the echo in the room. Of course, you can do it if you have the comfort of having an echocardiographer available. It doesn't harm, but normally not. We don't have anesthesia in the room, as said, so it's really minimalistic. 96% of cases transfemoral, also thanks to more and more shockwave-assisted transfemoral access. And then we have 4% of cases left for alternative access. That's for me, it has to be transvascular. For me, it's a percutaneous transaxillary as the first approach. If not possible, I'll screen for transcaval. I think transcarotid is maybe also valuable access if you have a good surgical help.
That's very useful for us. Thank you so much. Another hot topic, Ole, is mitral insufficiency. Mm-hmm. So as a very experienced structuralist, what do you see in the future in terms of transcatheter solutions? When we're going to use repair versus perhaps replacement?
Yeah, I mean, that's a difficult question, of course, because mitral valve disease is so much more complex than aortic stenosis. Aortic stenosis is a single entity of disease, and you have to replace the valve. That's basically it, and then it's either surgery or TAVR. Mitral disease, it's very complex. I mean, you have multiple. It can be primary, degenerative mitral regurgitation. It can be secondary, functional due to heart failure. So already there, that can have effect on which therapies you think and believe are going to be the better ones. Also, if in the degenerative, the primary one is a simple prolapse, or is it a cleft, or is it whatever, the Barlow's disease, it can be so many different pathologies. So I think in the future, where probably it's going to, I think now for quite some time still, it has shown that the repair therapies are safer than the replacement therapies. The replacement therapies are still, we're looking at it, trying to do this already for 10 years. And you see how few really finally made it to some even good studies. Mm-hmm. Not even commercially yes. Nothing. I mean, we only have like 10 which is transapical. It's not the future for me at all. The future should be transeptal, by the way. I mean, that I strongly believe. Sure. As long as it stays transapical, it's still a surgical procedure in a way. It has to be transeptal. But I think definitely there are coming replacement therapies. Of course, it is a bigger footprint in the heart. It is you can have interaction with LVOT. Mm-hmm. That's an issue. You may have valve degeneration issues. You may have valve thrombosis issues. So even some believe that if you have a fantastic replacement therapy, that this will wipe out the entire repair. I don't think so. Mm-hmm. I mean, there will be, depending on the disease and the pathogenesis behind, there will be a market for and a need for replacement, especially those where with repair you cannot obtain a good result. But repair has shown, especially if you look to all the mitral tear results, it's an extremely safe procedure. Yes, yeah. And that's something in medicine. First, do not harm. Yes, and I think that's something the complication rate is extremely low, almost zero. It's a free ride, you can do it, and then most of the time with the technologies we have now, like if we talk then, for example, MitraClip with the evolution with the G4 generation 4, that you can get as an interventionist so much better results, even in complex anatomies compared to 10 years ago. So I think that's going in a good direction, but there's other repairs maybe in the future too, maybe annuloplasty, maybe they crack the code to finally get a good annuloplasty device, transcatheter based. or catheter based, or maybe some leaflet elongation or prolongation or spacers. So there's a lot of different therapies coming, I think, and that's also justified in the mitral space where it's such a complex disease. So I think there's going to be space and need for all of these.
Ole, this was fantastic. Thank you so much for your contribution in the field and for being here with us at InCor, contributing also with Triple Y.